All right. So thank you everybody for being here. I'm going to do my best to admit people. This is going to be a little tricky while I'm in here. Let me see. Can I remember what I said about my cursor was going to disappear when I was up here? Because there's somebody in the waiting room and I can't let them in. So hold on, let me try and stop sharing so I can do that really quick. Okay. I I'll do what I can to, whoops, where did that go? All right, sorry about that, guys and gals. There we go. Let's try this again. Okay. And now here we go. If there are any late attendees, I might have trouble admitting them.
Okay.
That's the only thing I'm worried about.
Yeah, me too. I'm a little worried
Someone
about that
just
also.
someone just is trying to add right now. So I don't know if I'm able to do that without let me see. I don't know if I'm able
Yeah,
to do
you'd
that
have to
without
we have
stopping.
to hop in and out.
Yeah, and I don't want to keep people waiting, but I don't want to keep people from getting in
Yeah,
either.
let's give it let's you know what, Alex? Let's give it 1 or 2 more minutes and then
Okay.
because we'll give it till 8 after and then we will start. Sorry about
Okay.
this. We did come in early and we've been working on this for 15 minutes, but it's only letting one person be host. So we're trying to go back and forth with that. And there's nothing, the little dots, nothing's working.
All right.
Okay, I just reclaimed host to see here.
Well, let me start off with my disclaimer. I think that's something we can do without having the slide up. So for everybody that's joined today, we're going to be going over PTSD and first responders. A lot of this information may be stuff that you're very familiar with. Some of it might be a bit of an overview, where we're kind of going to get into some stuff that maybe you haven't heard of before is going to be when we get into the generational trauma and ACEs, which is called adverse childhood experiences. Now, once we get into that type of material, it can be really activating. So I just want to give you just, consent, an opportunity to consent to being here, being a part of this discussion. Obviously, there's nothing that you're required to do on your part as far as participation goes. If you have any questions that you want to ask, we've already agreed that we're going to stop the recording before the discussion starts. But I always like to let people know that because I think that the material can sometimes be a little jarring, and I just like to let everybody know before we get started. Um, the other thing we're going to talk about, we're going to start with PTSD. We're going to talk about kind of the company that PTSD keeps. So I think some things kind of get lumped in all as PTSD when it's not, or someone might be having an experience at work that's causing suffering or distress, and they don't have a name for it. So we're not going to go too into detail into these terms other than to lightly go over them, define them, reference what they are, maybe add a little bit of context to it, and then move through that. But one of those terms is going to be moral injury, which we are going to get into much more deeply on Friday. I hope you join us for that. Then we're going to get into the generational trauma, the adverse childhood experiences, kind of the history with that, because when we think about how first responders are wounded, it really is in one of three main ways. There's going to be obviously the calls that are around the exposure to trauma, but there's also going to be the trauma that we come preloaded with. And that can come by way of childhood experiences. And like I said, the trauma that we inherit from our parents and grandparents. Now, that's not to say that I should say that's not to create this tug and pull of like, oh, well, it's coming from that, so it's not coming from that. It's all encompassing. It's all encompassing. I do firmly believe now we've never studied ACEs in first responders specifically, but there are some theories that the adverse childhood experience of a first responder is significantly higher than the general population. That has not been proven, or I should say, that has not been authenticated and researched. However, I suspect that even though that might put first responders at higher risk for things like suicide, substance abuse, cancer, mental health conditions of all kinds, I think it also is what draws first responders to this job in the first place. I think that many of us may have grown up in chaotic homes, which is why we find ourselves feeling right at home on chaotic scenes. So I suspect that I think one thing that goes overlooked is the fact that if you're in this field, you came resilient. You are resilient. Resilience isn't something that you need to earn along the way. It's something you need to remember that you always had. So With that, I think we're done having some admins and admissions, and we can get started, do you think? Yeah, okay. So let me go ahead and try sharing the screen again. I need to be host. There we go. Okay. Thank you all for being patient with us. Having no co-host does definitely make it a challenge. Okay. So that was our intro. So let's go ahead and start with our first part, which is talking about what PTSD is. Now, post-traumatic stress disorder, as defined by the DSM-5, is characterized by the development of specific symptoms following exposure to one or more traumatic events, such as an actual or threatened death, serious injury, or sexual violence. Going back really quick, I want to say if you've heard the term PTSI, that is gaining more popularity and more demand as an alternative to PTSD. We don't use it in the research context because it's not what it's formally referred to as yet. So as of now, it is still PTSD. The way I like to kind of address PTSI, which is post-traumatic stress injury, is if I'm speaking to somebody and that's how they want to describe their wound as PTSI, I will follow their lead and refer to it as PTSI. But for the sake of sticking to what I've referred to here, which is the APA's criteria of what PTSD is, I'm going to be calling it PTSD moving forward. Okay, so the PTSD criteria. So a little disclaimer, I have a couple disclaimers actually, you'll hear throughout this thing, but one of them is that we're not going to go through the PTSD criteria line by line because number one, it's a lot. I am going to give you the overview of it because there is a piece of it that I want to point out that I think is the most applicable to you all here in this audience. And that is that, and we'll get to that, but before we get to that, what I want to make sure we don't do is even if we went through each criteria, because there's several criteria to determining PTSD, the last thing I want to encourage is people to kind of just sit there and silently go like, check, 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 and then you're self-diagnosing yourself or attempting to self-diagnose yourself with PTSD. So just know that even if you were to look this up on your own, which I still highly encourage you to do, you can find it online, without the diagnosis by a licensed clinician, it's not a diagnosis. So we have to work with a clinician so that they can rule in or rule out or, use their differential diagnosis to determine if what you're experiencing truly is PTSD or if it's co-occurring with something else or if it's something else entirely. Okay, so this is just a kind of an overview of what PTSD is, what your therapist is going to go through to determine whether or not what you're experiencing is PTSD. And then there's a couple of more pages that get into children ages 6 and younger. So it is very comprehensive. But there is one part that I want to point out to you, which is this highlighted area under criterion A, which criterion A states exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways. And in number 4, it says experiencing repeated or extreme exposure to aversive details of the traumatic events. Example given, first responders. Okay, so this is where your exposure to traumatic things repetitively could cause PTSD. Not everything you're going to experience, not everything you're going to run on when you are responding to these calls in whatever capacity that you do this is going to lead to PTSD. And that's something that I think gets lost in the conversation is we're told, well, if you work in this field, you're all going to get it. No, that's not at all the case. Is everyone going to be affected by it one way or another? Potentially. And yes, if it happens to a coworker of yours or one of your best friends that you came up in the academy with, it's going to affect you because you don't want to see your friends and your family suffering. But this idea that just because we're exposed to it means we're automatically going to get it is not true. But I do want to point out that that is where the DSM, and this was added in the last few updates. So that is an important development in PTSD. Now note that the criterion A4 does not apply to exposure through electronic media, television, movies, or pictures unless the exposure is work related. Where I'm going to challenge this and where I'm also going to agree with it is that on one hand, I think news and social media has changed things. We've watched people get murdered on TV in the last few years, especially. I'm thinking George Floyd, I'm thinking recently with Kirk. Those kind of things I think are going to shift the narrative around that a little bit. But that said, and really, it really changed with 9/11. Never in the history of broadcasting did we watch thousands of people die on loop for 24 hours a day for several days. We had never interrupted broadcasting before like we did in 2001. So that really kind of changed the direction and what kind of things media exposed us to. But what I want to point out is there are some studies that will research interventions for PTSD. One that comes to mind is Tetris, and the idea that we can use Tetris to offset the hold that PTSD might have after witnessing a traumatic event. The problem is that they usually take their subjects and they expose them to a scary movie. And then they assess their intrusive thoughts following that scary movie. But right here in the note for criterion 4A, it says that it shouldn't be an electronic media type thing that causes the PTSD. So you have to question that when you see some of these studies saying that this or that works for PTSD. Okay. All right, so PTSD symptoms. So I will go over these very briefly, which is the list that you see here: intrusive thoughts, hypervigilance, exaggerated startle response, sleep disturbance, nightmares, irritability, self-destructive behavior, avoidance, diminished interest, negative emotional state. And then I have the little asterisks next to depression, because approximately half of people who are diagnosed with PTSD also have a co-occurring diagnosis of major depressive disorder. And it is not suspected that they had the depression before the PTSD. It's suspected that it is a comorbidity of the PTSD. And that is a very big finding. Now, one of the things I want to point out about those, so I'm going to go back really quick so you can kind of take a look at them, is if you have one of these, and let's say no history of PTSD, that doesn't mean that it's not something worthy of seeking treatment or assistance for. Any one of these by themselves can cause a disruption in our ordinary life. I will say for me personally, hypervigilance outside of the history of PTSD that I have is the thing that kind of creeps up every few months that I have to address and work on. And if I was to tell myself, oh, well, it's just hypervigilance, it's not, or I'm sorry, not hypervigilance, intrusive thoughts is what I deal with, intrusive thoughts. If I told myself, oh, it's not that big of a deal, I'll just, whatever, I might dismiss something that could be worked on pretty easily, and it is. But you don't need to have this accumulation of all of them to warrant some sort of treatment and therapy. Okay. All right, so acute stress disorder. Now, if I've asked people before, hey, what's the difference between PTSD and PTSI? They give me this definition. So another thing about changing the terms around what PTSD is that it causes confusion with the definitions. But acute stress disorder is essentially the same thing as PTSD, but it only lasts a month. So it often resolves on its own, but it's still something worth addressing and working with a therapist on. So let's say you have a traumatic call, it's really sitting with you, you're starting to have nightmares a couple days later, you're having hypervigilance, you're getting real, testy to be around, and maybe even experiencing whatever it might be. Go get, check in with the therapist that you already work with. Hopefully you've already got an established relationship with somebody, because until it hits the 1 month mark, it's not going to be considered PTSD. But that doesn't mean there isn't time to get in there and intervene and start treatments or go do EMDR or something to process that event. There's no need to suffer. There's no prerequisite of suffering that needs to happen before you're worthy and eligible of working with a therapist. But just so you know, for the full definition of everything, that is going to be, I was able to admit them. I just admitted two more. That's what acute stress disorder is. Okay. Now you're going to hear me say this again before the end of this. It's a very, I think, powerful quote by Dr. Viktor Frankl. If you've ever read the book A Man's Search for Meaning, or if you haven't, it's an incredible book. And he states that an abnormal response to an abnormal situation is normal behavior. Okay. It is completely normal, I would say natural even, to respond this way to some of the things that we're exposed to. And Dr. Viktor Frankl, if you're not familiar with his work, he was a survivor. He's since passed away, but he was a survivor of the Holocaust. He was in Auschwitz for a couple of years, and he showed up essentially with his dissertation in hand. He had been working on his PhD. They ripped it up in front of him. All these horrible things happened to him. He lost his entire family. And while he was in the concentration camp, he wrote what would eventually become this book, The Man's Search for Meaning. And he talks quite a great deal about suffering and trauma, and that at the end of everything, it comes down to our mindset. And it comes down to the way that we show up within our lives and allow ourselves the grace to experience this. And who better than someone like that to, teach us that? Okay. So there is a quote that is attributed to Sigmund Freud, but and I spelled his name wrong, but um, attributed to Sigmund Freud, but not quite. He didn't exactly say this, but it is based on the work that he did, which is that unexpressed emotions will never die. They are buried alive and will come forth later in uglier ways. Now, so if we don't let ourselves feel our feelings and process those emotions and let ourselves get uncomfortable with the experience and the full spectrum of what it is to be a human being working in these kind of environments, it doesn't just go away. Sometimes it's like, oh, maybe you run a really bad pediatric call and then you've got calls holding. Maybe you've got to, get off shift and then you've got kids to take care of and you've got an overtime shift and you've got projects and you've got degrees that you're finishing up. So a lot of times, one of the most common coping mechanisms we see is people staying busy. How many people here know someone or are someone who has 4 jobs and they're getting a PhD and going through, there's people that will do that. And when I see that, I'm, number one, obviously, congratulations on the accomplishments. And also, are you okay? Because I'm wondering, what are we avoiding? What kind of emotions are we avoiding? So the next scene is going to be, so I have a clip that I want to show you. And this demonstrates exactly that. What happens when we shove our emotions down? They will come out in their own way. And the scene is from the TV show The Pit. So if you're in the middle of watching it or you haven't gotten to the end of it yet, you can look away and it won't ruin the storyline for you. But you can listen in if you would like, because the voiceover that I created is a clip from a podcast of Noah Wiley being interviewed, talking to the interviewer about an experience his mother had when she watched this scene from The Pit. Now, it also, those of you who have watched the show and understand what's happened, um, I think that this is PTSD, but it's also a very good example of moral injury. Okay, it's a very good example of what happened because he has to, and this is very evident in the very first episode, that he has flashbacks of COVID and when he had to take his mentor off the ventilator because they had to give it to other people, and he talks about that in here. But that would also cause a moral injury, not only the PTSD. So I'm going to let you watch this now.
Ultimately, in our backstory, he had to be taken off the life support to give it to another patient who had a better chance of survival, and then everybody died. And it was a traumatic memory that my character has just not really ever dealt with. He's moved on, and today is a day he probably should have stayed home, but today he went to work, and as a result, he's just getting triggered by different things, and those memories begin to come up with greater and greater frequency and greater poignancy, to the point where he becomes totally debilitated by them. And the aggregate of all of that grief and all of that suppressed emotion just overwhelms him. And it was interesting. My mother was an orthopedic nurse and an operating room nurse. She worked for 20 years at a hospital in Hollywood. And she came over for breakfast last Sunday, and she came into the kitchen, and within 5 seconds of being there, she said, Noah, I can't stop thinking about last week's episode and that scene where you were listing all the people who died. And I think I had my own PTSD reaction. I suddenly remembered everybody. I remembered the 4-year-old. I remembered the pregnant woman with the baby. I remembered the gang member that I tried to keep alive by squeezing 2 units of blood. And she's just listing these names, and she's, getting teary-eyed. And she finishes, and I said, my goodness, Mom, I was on a medical show for 15 years. You never told me that. And she said, well, that wasn't real. I said, well, this one wasn't either. And she said, but it felt real. And it brought all that up for me. Isn't that funny? And so here I am in my own kitchen having this lovely sort of cathartic and catalytic moment with my mother. And I asked her, I said, the 4-year-old, when was that? She said, oh, I think your brother was probably about 4 at the time. I think that's why it hit me. And then I thought to myself, oh, so you came home and you made us dinner that night and you helped us with our homework. Wow.
And she's carried that painful memory for all these years.
That's 35 years that's been in there. Came out last Sunday.
Very powerful scene. Very powerful scene and testimony. Okay, so shifting into mental health statistics, my kind of thing on this is that I think that the research and the statistics are important, but they are not all encompassing. It is impossible for us to encapsulate the full lived experience of each single provider in a number. And while they give us guidance and they justify more research and more funds allocated for different initiatives, I try not to get too hung up on them because they're constantly evolving. And you have to ask yourself, where is the population coming from that they're, checking after 5 years? Anything that was done before COVID, I think, is outdated. We need to revise those things. But the way budgets work and the way, different things work, we don't always have the ability to. So, but with that, I still think they're valuable. And so here are just a few of them, which is that up to 30% of first responders develop PTSD. Okay, so again, it's not all of them, but it is a great amount of them. 30% is still a lot. We know that first responders are exposed to more trauma than civilians. We have studied that. And there is a higher risk of suicide with PTSD. Now, the last one is more of a general population, but if you think to yourself, there's a higher risk of suicide with PTSD, and there's more trauma exposed to the first responder than the civilians, it's automatically going to make sense why there is a higher risk of both suicide and PTSD in your first responders. Okay, suicide statistics. So one study published found that 46.8% of firefighters had suicidal ideation. Another study found law enforcement officers are 54% more likely to die of suicide than in the line of duty, which is shocking considering how dangerous that line of work is. The statistics are very high for firefighters as well. And then EMS providers are 39% more likely to die by suicide than the public. Now, this last one gets shared the most, I think, when it comes to EMS providers. The nuance with this is that if you look at the data, if you look at the population that they collected this data from, it's a mixed population of dual function firefighter EMS. It's not just EMS. So while it's still valuable to know about, there is a deficiency in EMS specific research. Most of the time when you see something that researches EMTs, paramedics, you have to look at the population that they're pulling from. And a lot of times they are looking specifically at, or they're not looking specifically at EMS providers that work on an ambulance. They're mixing the population with firefighters as well. And what can also convolute some of this data is because sometimes they're working with the occupational data might be incomplete or difficult to capture because you have a lot of first responders that are volunteers. They make up a huge part of our force in the United States. And so there's some nuances with this, but that said, I still think they're important. It's just important to understand and recognize the big picture. What we do know is there's a problem. That's what we do know. We know there's a problem, and we do know that everybody, that there's a problem that needs to be addressed. Okay. So the company that trauma keeps. So this is where we're going to get into those other areas that have, that might co-occur or might go unnoticed, or maybe it's an experience that you've had, but you didn't know there was a name to it. I just kind of want to do an overview of what these things are. Okay, one of them is administrative betrayal. This is when leaders or institutions that are supposed to protect and support responders instead diminish, punish, or fail them. This betrayal of trust can intensify trauma and erode company morale. So an example I'll give very briefly without getting too far into the stories is one of my most memorable traumatic calls that I had ever experienced led to a write-up instead of a check-in. And the write-up was because we didn't get the wheels of our ambulance moving within 60 seconds. So we had what's called a shoot delay. Now, this was a very complex layered call where a lot of things went wrong, where we were failed by our dispatchers, and we took a nurse from the jail that wasn't supposed to leave the jail without a nurse, and we took her with us because we didn't have fire department on a 19-year-old cardiac arrest, 9 months pregnant. So there was a lot of things happening. And at the end of it, it was one of the worst calls we had ever experienced. And instead of checking in on us, they said, hey, by the way, you have a write-up. And that's not to say that just because we have a bad call, we shouldn't be held accountable. But I'd had plenty of shoot delays before and never got a write-up. And at the very least, I think what would have changed that administrative betrayal, would have offset that administrative betrayal, would have been like, hey, let's talk about, like, are you good? Like, that looked like a really rough call. I'm sorry that happened. Unfortunately, we're cracking down on people with this. I have to give you this write-up. At least it would have come after the fact, and it didn't. So that's just one example. Disenfranchised grief. Okay, so just disenfranchised grief is grief that isn't openly acknowledged, socially supported, or publicly mourned. So this is common in first responders and healthcare providers alike, who lose a patient, but feel like they don't have a right to grieve somebody that they didn't know. Now, it's not to mean that, you'll go through the same 6 to 12 month. I mean, really, there's no timeline on grief, but it's not to say that you'll go through the same amount of grief that you will a family member or a friend, but there is grief that occurs with your patients that are complete strangers to you, even after the call. And I remember one of the first calls that I was affected, I went and hid when I cried because I was so embarrassed because I thought I was the only one. And so a lot of times we think we're the only one, and so we hide it. And that just leads to complications when in reality, it is a completely human experience to grieve people you never knew. Okay. So compassion is a motivational state. I mean, it is an action, but it is a motivational state of wanting to ease one's suffering. And when we get into a state of compassion fatigue, we lack the motivation to ease another person's suffering. And so emotional and physical exhaustion from prolonged exposure to other suffering leads to reduced empathy and detachment is kind of the formal definition. But where I think it occurs is a lack of boundaries in some ways, but it's also a lack of understanding how empathy works. So we hear a lot of talk about how we need to be more empathetic. However, we don't talk about how empathy is supposed to serve us in the moment, and then we're supposed to let it go. So sympathy is feeling something for somebody. Empathy is feeling something with somebody. So, for example, after I had a back injury, my advocacy, if I had stayed on the ambulance, which I didn't, but my advocacy for patients with a back injury would have gone up tenfold because I would have understood. Like, I don't understand what it feels like to be them, but I have something to relate it to. Whereas before that experience, I didn't. Okay. Now that's one example. Let's take something that's a little bit heavier, like the loss of a child or something. Those of you who had kids after you started in this field probably handled pediatric calls a little differently after you had kids versus before. That's empathy. Okay. Now, empathy is designed for us to connect with somebody, but then it's ours to discharge and release. It's not ours to keep. And when we keep collecting these experiences and these grief from other people, we get overloaded with it. And I think that's where compassion fatigue comes from, is that then we just get turned off to it. Is subconsciously, we're just like, no, I don't have enough I don't have any more compassion to go around. Well, it's because you are at full capacity, because no one taught you that it's okay to discharge that. It's okay to decide, like, hey, I can only take so much. This is mine to let go, and among other things, obviously. But I think that's where some of it comes from. Okay, moral injury is the psychological, spiritual, and social harm from perpetuating, witnessing, or failing to prevent acts that violate one's moral beliefs. Okay, so this is a little challenging to summarize right now, so I'll just tell you, please come back on Friday. We have a whole hour dedicated to moral injury. What I will say is that in the last year, we have uncovered some pretty remarkable research that has suggested that moral injury is as high, if not higher, of a risk factor to suicide in first responders and healthcare workers. I suspect that we are going to be hearing a lot more about moral injury in the next decade, the way we've seen an influx of PTSD in the last 2 decades. And I just found this out this morning and I have to go back, actually, because I was getting ready while I found this out. I have to go back to my lecture that I'm giving you on Friday and revise it, because there's already been an update in it, which is that moral injury is officially recognized by the APA in the DSM-5, meaning it is a diagnostic condition, diagnosable condition, whereas previously, before, people were like, I mean, it's a thing, but it's such an eroding experience that for it to finally be acknowledged in the DSM is going to be big progress for us. So I'm going to go back and have to review that. But maladaptive coping mechanisms. Okay, so what I want you to know about coping mechanisms is that they all work. That's why you do them, okay? Now, what makes them maladaptive versus adaptive is whether or not they create more problems than they solve, or whether or not they create more solutions than problems. So, for example, if somebody copes with running, could there be a problem with too much running? Sure. But the benefits are still going to outweigh the risks. Whereas alcohol, which is our most common coping mechanism on top of staying busy, I think personally, that would be my belief, on top of staying busy, will create more problems than it solves. So alcohol is a very effective coping mechanism, but it's maladaptive. And so it only creates more problems the longer you utilize it. Now, one of the also falls under coping mechanisms, but whether or not it's adaptive or maladaptive, it depends how it's used. Okay. Where I've seen dark humor go wrong is going to be when it's done so publicly. Okay. So dark humor. So it was studied at Stanford. And what they determined was that dark humor, when shared amongst immediately affected peers, so people who were in the trenches with you on the call, it diffuses energy. It creates a bond. And when it diffuses energy, it's basically you're at a tipping point where you are either going to cry or you're going to laugh. And guess which one we're more comfortable doing in front of our peers? Laughing. Okay, it's just a release valve. However, the further out you dissipate that, or you widen your audience, the more it just turns it's just poor behavior. At that point, it's not a coping mechanism. It's someone just trying to go for the shock value. Then you take it and you put it on social media. And we've seen extreme backlash when a first responder shared a dark humor joke that they shared with their provider or with their partner, and it just goes sideways. The one thing to keep in mind with dark humor is that the joke is usually about the situation, not about the person's characteristics that they were inherently born with. Okay. So we don't want to make dark humor jokes about gender. We don't want to make dark humors about orientation, about disabilities. Those things aren't funny. And so we have to make sure that when we're utilizing dark humor, make light of the situation, not of the person. That will be a big difference there. Yeah, we'll move on with that. Okay. Doing really good on time. Okay, so now we're going to get into the adverse childhood experiences and generational trauma. Okay, so we're going to start with generational trauma. So generational trauma is defined as trauma experienced by one generation that can impact the mental, emotional, and physical well-being of subsequent generations, even if they did not directly experience the traumatic events themselves. Now, if your BS detector is going off and you're like, there's no way that could be possible, I was in the same boat. I 100% was in the same boat, mostly because maybe denial, because I've now realized I inherited a lot of trauma from both my parents. And I also, because of the sacrifices they made, I'm a first generation American. My mother grew up in very, unthinkable poverty. My dad, a constant war. I'm also a Civil War survivor, as is my sister and my mother was. Those were things that I inherited, and I denied the idea that I have such a good life because of the sacrifices they made. I felt silly thinking that that could affect me in any way. Well, it turns out it actually did. So I'm going to explain the science behind it and how that might be possible. And it wasn't until I got into my PhD program and they explained it like this, and I started looking into research around epigenetics, that I went, oh, this might be a thing. Okay. All right. So taking a look at this picture. So when your grandmother was pregnant with your mother at 16 weeks gestation, so 4 months into her pregnancy, your mother developed all the eggs that she would carry throughout her lifetime, including the one that would one day go to make you. And this idea is that you are within your grandmother's womb for those 5 months. You're literally, the DNA that would one day create you was in your grandmother's womb for those 5 months. And then your mother carried you until, of course, you were born. And there is a study that was done on mice. And you might have heard the study before. So a group of researchers took a group of male mice They put them in a cage and they lined it with water. And then they exposed, so they have their little feet in the water, exposed to the water. Then they released a scent to these mice. And it was a scent that it was a chemical that they released that would either give, either cherry blossoms or almond extract was the scent that it was characterized as. And every time they released the scent, they would send electrical impulses to the water, which would shock their feet. They would release the scent, electrical impulses, shock their feet, release the scent. What do you think happened over and over again? Anxiety, fear, terror, their heart rates would go up. They were stressed. They did this over and over again until they conditioned them so well that number one, the genetic expressions of their DNA had changed, their epigenetics, and that all they had to do was expose them to the chemical, to the scent, and they'd have the same physiological reaction without the exposure to the electrical impulses. Then they took that group of male mice and they artificially inseminated a group of female mice without giving them any interaction whatsoever. They were kept completely separate. And then they gave birth to the pups and they exposed those pups to the scent. And guess what happened? They had the same exact reaction as the sperm donor male pups did. Then they reproduced those pups again and again and again. And they had the same reaction as the original pups that never had any interaction with the female ones. Now, the first and most obvious dispute of this is they're mice, right? Understandably so. We can't do this on humans. We get in trouble nowadays. Like they would never approve that. So it's a good thing we can't do this on humans. It's very sad that we have to do it on mice. And so I definitely am grateful for their contribution to science, but they also reproduce a lot faster. So we're able to look at generations and lineage down. Now, when I hear that story told, because it's a very sensationalized story that gets told on social media quite a bit, what they don't say is that same group of researchers went back into the lab a few days or a few years later, and they showed that you could actually reverse the trauma. So it wasn't just about passing down generational trauma through your lineage, you could also reverse it. So they took the same conditions, they conditioned them the same way, got them to reproduce, had the changes in genetic expression. It's not changing the DNA, it's changing the epigenetics, changes in the genetic expression, and or the markers that were, influencing or indicative of the genetic expression, I should say. And they reversed the experience with love and safety. Essentially, they gave them a love safe, environment, not exposed to anything. And after enough times of re-exposing them to that, they reversed what they were initially able to evoke in the original group. So trauma is reversible. Okay. So when you start thinking about like how there's generations of firefighters or generations of paramedics or generations of cops, it makes you wonder how much of that potentially was passed down. And then if you screenshot or take a picture of those two QR codes down there, that'll take you to both those studies so you can take a look at them yourself. What I will say though is if this interests you more, if you research anything around ancestral trauma, generational trauma, intergenerational trauma, it'll yield something along those same results, and you can look into a few different books on the topic. Okay, so now we're going to get into adverse childhood experiences. So an adverse childhood experiences, or ACEs, are potentially traumatic events that occur in childhood before the age of 18. Now, many of you may have already, many of you may have already heard of an ACE or an ACE score, but you may not be aware of where it originated. So Dr. Folletti worked for Kaiser Permanente in California, in San Diego, California. He had a obesity and weight loss specialist clinic where he worked with people who had a history of obesity or morbid obesity. And he had a handful of patients that kept dropping out of their program, meaning they would lose, because these were people who were up to 500 pounds overweight. And they would lose a significant amount of weight, 100, 200, 300 pounds, and then they would drop out of the program. He'd never see them again, or they would gain all their weight back. And so he was trying to figure out, like, why is this happening? Let me bring back these individuals and let's interview them and get more information as to why. What's the disconnect? How are they becoming so successful? And then it's falling off. And so he brought them back and he'd ask questions like, how much did you weigh how much did you weigh when you started preschool? How much did you weigh when you were born? How much did you weigh when you graduated high school? How old were you when you got married? How old were you when you know, this and that? And then he accidentally asked one day, he asked a woman, how much did you weigh when you had your first sexual experience? And what he meant to ask was, how old were you? And that's what he had been asking all of his clients, both male and female. And when he asked her, how much did you weigh? She said 40 pounds. And he said, no, how much did you weigh? Like he didn't catch himself saying the wrong, really the right question. He didn't catch himself saying it. And she insisted it was 40 pounds. And he found out that her first sexual experience, this was 1985, by the way, her first experience, sexual experience was with her father. So he had a case of incest on his hands, which back then and still very much now, we don't believe incest to be very common, but it was thought to be almost unheard of back then. So realizing his mistake, he thought, oh my gosh, like what? Maybe I need to ask more people this question. And what they did, and he got his other researchers involved, they brought in all these, I can't remember the exact number of people that he brought in, but they were all from his clinic. So it was a very special population. It wasn't from the general population. And what they found was that over 50% of these dropouts had a history of sexual abuse, mostly in childhood. And he thought, this is a huge finding. Like, this must mean something. So it's 1990. Okay. So it's been 5 years since he's collected this data, continued to collect this data. And he presents it at a conference of other psychiatrists, psychologists, and medical physicians. And he presents it at this conference in 1990 in Atlanta. And they mock him for it. They think he's crazy. They go, well, you're foolish to, incest isn't that common. You're foolish to believe your patients. I mean, just completely dismissed his findings. And mind you, it is, you know, it's survey data, right? It's not official formal data, but it was a finding. It's like where there's smoke, there's fire. So he's indicating there's smoke and asking them, like, we need to go in further. We need to investigate this and find out where the fire is coming from. And so that night he sits at dinner next to a member of the CDC, an epidemiologist. And he leans over to him and he says, people will always find flaws with data when the subject number is low and it's from a specialized population, but not if there's thousands and not if it's of the general pop. And that was the day that the ACEs study was born. 5 years later, they would publish their findings, which we're going to go over right now, which links childhood experiences to adult onset behavioral, psychological, and medical physical conditions. It's one of the only studies that is this widely cited, it's been repeatable. And I think they studied, God, it was tens of thousands at this point. But they have determined that, you know, one of the most important things we can do is to prevent childhood trauma and childhood abuse to offset the occurrence of a multitude of conditions as an adult. But the second best thing is to heal as adults. We can do that. And that's something that is missing from this type of conversation, is that we can go back and especially when we do some more subconscious work, some deeper work, which we'll talk about at the very end of this presentation, we can go back and heal those experiences to change the, you know, course of our future. Okay, so going into the next few slides, I really want to emphasize that if you recognize yourself in, because I'm going to go over what the ACE survey is, and if you recognize yourself in any of this, I'll tell you right now, my ACE score is very high. That doesn't mean that I'm going to get COPD, cancer, diabetes. You know, it doesn't mean I'm going to get all those things. It just means I'm at higher risk of them. And that it means that my cancer screening should probably start a little earlier. I probably shouldn't go more than 6 months or a year of the recommended time. And that I have to take extra steps to work on healing those versions of me, the younger versions of me, to change the way, you know, my fate goes forward, just because I know there's a risk. So this is not meant to diagnose anybody. It's not meant to be doom and gloom. These numbers can be very sensationalized, and I just want to keep that information in context. Okay. So the ACE survey broke things into 2 categories, which was abuse and household dysfunction. So if any of these happened before the age of 18, they counted as 1 point. Okay, so psychological abuse, physical abuse, sexual abuse Was there substance abuse in the home by any of the caregivers? Was there mental illness by any of the caregivers in the home? Was there domestic violence between parents or caregivers in the home? And was there any criminal behavior or incarceration by either or both parents in the home? They went on and expanded it because they've repeated this ACE study and expanded on it to include physical neglect, emotional neglect, and divorce. Okay. Now let's get into some of the stats. Now, it's considered to be 1 to 3 ACEs are considered mild to moderate, and anything over 4 is considered a high ACE score. Okay, so we'll start with the first ones, which is that 69% of adults experience at least 1 ACE. And this was across all demographics, all social classes, all backgrounds. And what this told the researchers is that some sort of trauma in childhood is actually incredibly common. Next, 5 of the 10 leading causes of death are associated with an ACE: heart disease, cancer, respiratory disease, diabetes, and suicide. This is Suicide Prevention Month. We're talking about the risk of suicide associated with PTSD. This is all kind of encompassing and circling back. And females and people of color are at greater risk of experiencing 4 or more ACEs. So while it's incredibly common across all demographics, there is a disproportionately higher amount of adverse child experiences that happen to females and people of color. Oops. All right, so let's get into the, have somebody waiting, but I don't want to, okay. So 4 or more ACEs. So if you have 4 or more ACEs, you are 390% more likely to develop COPD, 460% more likely to experience depression, 1,200% more likely to attempt suicide, 7 times more likely to struggle with alcohol addiction, and it doubles the risk of heart disease and cancer. So when you look at this, I see a combination of physical and psychological ailments that just undeniably suggests, let's just say, I don't want to say proves, that the mind and body are connected. It's all one and the same. Where one goes, the other follows. If you're really good at your workout routine, but you don't, if you're really good at your workout routine, but you don't, believe in checking in with a therapist, then we're missing half of it. Ooh, hold on, admit. I just admitted somebody. Okay, good. Okay, so moving on, let's go. All right, so the last statistic, and I think this is very eye-opening for those of us that are working out in the field. A male child that survives 6 or more ACEs is 46 times more likely to abuse intravenous drugs. And the reason this is so eye-opening is because, number one, had I understood this, I might have been a lot more compassionate and patient with my repeat patients who struggled with addiction. Now, that's not to say that I'm encouraging it or that I'm okay with it, but at the end of the day, what we're starting to understand about addiction is that it's the coping mechanism to the problem. It's not the problem itself. Okay, so the problem itself is the trauma. So Gabor Mate, who's a physician and author and addiction expert, he says that trauma is actually the gateway drug, not the drug itself. And that instead of saying, why the addiction, he says, why the pain? Where is that coming from? Where is it coming from that they feel the need that they have to survive with that pain, with this? And obviously, the repeated use of these substances definitely do contribute to it, but it's not where it actually starts. The idea that we're going to take 1 dose of a narcotic because we break our leg and become become addicted to that substance right away, that's just not the way we're starting to understand that addiction works. Okay, so trauma explains behavior, okay? It does not excuse it. And I think it's really important to mention this is because while I want it to enhance our capacity to understand where it's coming from and why people do what they do and why they struggle with these things, it's in no way meant to excuse it. Or if you're in a personal relationship or you have a family member that struggles with addiction, it doesn't mean you have to let your boundaries down or tolerate any certain behavior just because they had a traumatic life experience, just because at the end of the day, we might not be responsible for something bad that happened to us, but the healing is in fact our responsibility, right? We might not be to blame for what happened to us, but healing is 100% our responsibility. Okay, so ACE survey considerations. So first off, a little bit of the bad news, and this is my application of this, which is that I think the part that might be missing from the discussion is that if these ACEs occur under the age of 8, they may have more of a significant impact on our psyches than if they happen later on in life, up to 18. And the reason why is because up until from third trimester of gestation in your mother's womb to 8 years old, our brains are predominantly in delta and theta waves, which is more of a hypnotic state, and it makes us more impressionable. It makes our subconscious more impressionable. So if you've ever heard the saying that kids are sponges and you can teach them like several languages at a very young age, this is mainly why. Is because of the delta and theta waves that they're in. But you are not your ACE, I think is very important news here. And neither am I. And I think that, some times that can get lost in translation or lost in the discussion around this is that they are meant to act as indicators for us to take extra caution or extra precaution into preventative care. And it's no coincidence, if you're familiar with Kaiser Permanente, whatever you think about them, because they're both an insurance company and a hospital system, at least in California. I don't know if they're outside of the state of California, but that creates a lot of challenges in and of itself. But their big thing is prevention. They push prevention a lot, mostly because of the ACE study that they were a part of with the CDC. Okay. And then lastly, which you've heard me say before, is it's not too late to heal. There is work that can be done. It takes us showing up for it, and it takes the work with a professional, but it can be done. Okay. If you're interested in having some fun this holiday season, then maybe download the MD Calc app, and it has the ACE score on it. So I say this jokingly, but I do mean it sincerely, that it could change the way you look at the relationships you have within your family to find out what the ACE score of your parents or even grandparents were. Okay, so if you're interested in seeing that, I would download that app. Okay, I think we're doing okay. So we've got one last section that we're going to go through, and then I'm going to open it up for questions after that, okay? All right, so the work within. So this is rescuing your psyche. And the biggest thing I want to tell you is, even though I'm going to give you some ideas and some options to work with, you are the key ingredient. So I was working with, I work with a nonprofit that offers ketamine assisted therapy for women in EMS. And we recently had a retreat where one of the women, who's a paramedic, went back to work with a provider of some sort. And the provider just remarkably said, "Oh my God, what did you do? Like, what have you been doing?" And she's like, "I've done the work. Like, I did the work." And I love that she acknowledged that even though she had participated in group therapy, individual therapy, they did equine therapy, they did, yoga and somatic therapy, she was like, "I did it." And that's what I think is so important going forward is you might work with a professional. You absolutely need to. Please work with a professional. You might do EMDR. You might do ketamine therapy. You might be doing, even might take pharmaceuticals. Okay. There's nothing wrong with that if you need it. But at the end of the day, you're the person you are the most important component to any regimen that you start. Okay. So here are my foundations for healing the psyche, things that, if they are a part of your foundation, will make the process, I'm not going to say easier. It won't make it easier. It will just make it more effective. Okay. The first one is you have to want to heal. You have to want to heal. There are a lot of people, and I at one point was one of them, that are more attached to their injury than they are the idea of an outcome where they are not identified by their trauma. And that's not for us on the outside to judge them. It's us to check in with ourselves. Are we replaying the same story because we want to in one way or another, it's become something familiar. There's a saying, some of us would rather pick a familiar hell than any unknown. And if I told you that your life would look completely different a year from now, how many of you would be like, oh, I don't know if I want it to look different? Like, it could look different. You could have a better job, you could have a better promotion, you could make more money, you could have healthier relationships, but it could go in the opposite direction. So no matter what you're struggling with, no matter what you don't like about the condition or the circumstances of your life, a lot of times we'll keep it because we know what it is. And we do the same thing with our mental health. And then the second one, I think, comes, I don't think either of these are prerequisites, by the way. I just think we just need to get started on the work. But realizing that we're worthy of healing, the sense of self-worth that is stripped away with every traumatic experience is almost impossible. It's impossible to measure, but it is absolutely present. And I think it's something that to be said that the work that we do, it's in part, if not, a great foundation of it, it's learning how to love ourselves again, because we somehow lost touch with that along the way. Second one, we have to work with a professional. It might, you might have great coping mechanisms. It can be absolutely therapeutic and cathartic to have an artful, art expression, maybe working out, maybe running, maybe whatever it might be. It does not replace, so when I hear people say running's my therapy, it's not. It's really not. It's great to do. I highly recommend you keep doing it. But nothing will replace working with a therapist. Please don't go to ChatGPT for all your, therapeutic needs. It can't provide for you what another human being to mirror back and sit with you in that kind of space and help you navigate it. Therapists are there to show us where to look. They're not there to tell us what to see. They're there to show us where to look so we can find it on our own, but they can see the bigger picture. They can see where we're going before we get there. They can reflect things back to us, and they can help us process these things. I love therapists. I've been working with a therapist, not the same one since 2016, but I've been working with therapists for almost 10 years. At one point I had 3. I'm a big fan of therapy. Okay. 2 of them knew about each other though, so that's fine. All right. And then you have to practice good sleep hygiene. Now, if you had told me this when I was still in the field or even shortly after it, I would have scoffed. I'd have been like, no, not happening. Like, there's no way. Like, I would almost say, what's the point of having a good sleep schedule if I'm just going to go back on duty tomorrow? And the reality is that while you cannot control your sleep or the interruptions in sleep that you get while you're on shift, there is a lot that you can control when you're home. And many of us take those bad habits from work and bring them home with us. Or we're never raised with good sleep habits in the first place. There's a concept that I only recently heard of, which is growing up in sleep supportive homes. I didn't know that was a thing. I have a friend of mine who hosts EMS retreats, and we went, and this was separate from the Academy one, and we're there a couple of years ago, and her daughter comes, her daughter's 16, she was there helping out, and she comes, down the stairs, sleepy eyes, hair kind of a mess, because she slept until almost 1 p.m. You know what her mother said, who's a flight paramedic, by the way? She said, "Hey, honey, how'd you sleep?" You know what kind of jokes and razzing and shaming I would have gotten if I was even allowed to sleep that late? When I tell you, I had never understood what sleep supportive homes look like until I watched this family's dynamic. Sleep is the most important thing to them. And it helps that both her and her husband are flight medics, so they take their sleep very seriously. But here's why it's important, okay? Poor sleep both predicts and maintains PTSD, especially when REM sleep is disrupted. Protecting and treating sleep may reduce PTSD risk and improve recovery. And do you want to know the one thing that manages to interrupt REM? That's when our eyes are going back and forth, rapid eye movement, sleep. That one that interrupts REM the most? Alcohol. So we might drink, and I love my glass of wine, okay? We might drink to try and say like, oh, it helps me fall asleep, but it doesn't help you actually get restorative sleep. And what happens in REM is that REM takes all the events that happened that day and it filters it and files it into the hippocampus. And when it doesn't do that, then things don't get filed away well. Now think about a traumatic event. Now, when I worked at a fire department of 1,200 members, and my specialty there was pediatrics. So if there was a significant call that happened with pediatrics, I would get a phone call or a text message like, hey, you're going to get something across your desk. Can you take a look at the paperwork before I submit it? Yes. Okay. Extra set of eyes on it, had a good relationship with my crews. But every so often, I'd wake up to a text message that came in around 4 in the morning because somebody had been up all night, upset about a call that they had gotten off shift from that morning, and they were drunk. So what I always tell people is, I'm not going to sit here and tell you not to drink, because that's a big step from, and I mean, the reality is a lot of people aren't going to do that. But my big request is that if you have a traumatic event or you have a really bad shift where you're just like, I am not myself, like you don't even have to know why, go home and go to bed. Don't take any substances, don't do anything that's going to affect your REM, and let your brain do what it's supposed to do. And then your next opportunity to fix this is with EMDR, because that eye movement that they do in EMDR, if you're not familiar with it, they have you like go back and forth, back and forth, back and forth. What do you think you're doing? It's like a manual REM. So they're going to go back to the event that didn't get processed the night that it happened, and they're going to help you reprocess it so it goes into the hippocampus and it gets filed away in a manner that helps you understand that that event happened a long time ago. It didn't happen right now. That's the problem with PTSD, is it activates the parts of the brains that say that the threat is in front of you right now. And it doesn't understand, it doesn't comprehend that it's in the past. Okay, so reprogramming our subconscious mind. All right, so a couple of things I'm going to go over. There are ways to reprogram and influence our subconscious mind with conscious thought. It's just very challenging to do. Okay, it's just very challenging to do. I will say, and I've said this already before, talk therapy, big fan of it. I don't ever see myself in a time and place where I'm not working with a therapist of some sort. However, when it comes to reprogramming the subconscious, and I mean this with all the love, talk therapy isn't enough. It may not be enough. Let's put it that way. I don't want to impose too much of my bias on here. It may not be enough, but it's important that they co-occur. Okay, so talk therapy with the tools to reprogram the subconscious is a powerful dynamic, very powerful. Okay, so think about some of this subconscious programming. So sometimes there's patterns running in the background of our subconscious that aren't serving us. So we can have subconscious programming that do serve us as well, that we have good habits, and those are things that we want to keep. But the ones that cause suffering, that challenge the way that we show up in our lives, that maybe self-sabotage, codependency, we may have self-harm or addiction, maybe some blocks in intimacy, difficulty with intimacy. Some of these things may be, not always, this is not an exhaustive list and this is not always the case, but some of these things may be a subconscious programming that we're having challenges influencing in our conscious state. I'll explain what that means in a minute. And so these things can be heavily influenced by repeated exposure. So the work that you do, okay? It could be from childhood, it could be generational, it could be from a number of things. But all we know is that it goes into the subconscious and it controls our conscious thoughts. Have you ever heard that we only use 1 to 7% of our brain? We don't actually know that number to be exact, but we do know that a majority of our thoughts are filtered through the reticular activating system and get filtered into the subconscious, because if we process every thought that came through our brain, we might go mad. Some people probably do. Okay. All right. So subconscious programming. Who remembers what this is? Okay. If you said a landline, okay, I hear they're coming back. I have a few friends that have kids that they got them landlines because they don't want them to get, into the screen time type thing. But more specifically, this isn't just a landline. This is an answering machine. And answering machines came with the mechanism of outgoing messages. Now, what did you do? You recorded an outgoing message that said, hey, we're the Jones or we're the Johnson family, leave a message after the beep, and you leave a beep. Well, let's say you wanted to update that outgoing message. How effective would it be to update that outgoing message if you stood there and screamed at the outgoing message, the new outgoing message that you wanted? Would it work? No. Why? Because you have to find the record button. You have to find the record button, and you have to reprogram what you want it to say. The subconscious works the same exact way. We cannot access our subconscious with little exception. We cannot access our subconscious in a conscious state. So if we're standing here saying, I deal with avoidant attachment style, I can't get close to my spouse, I constantly cope with food, and I can't lose weight because food has become my coping mechanism, and you tell yourself over and over again that you want to change, but then you can't, it's probably because it's stuck in a subconscious loop. It's programming. Okay, so let's talk about how to find the record button. Also not an exhaustive list, just the 3 that we're going to go over today. EMDR. EMDR is a fantastic tool, not just for a specific trauma. There are some therapists out there that still subscribe to the earlier onsets or the earlier research of EMDR, which said that you had to have the specific event that occurred for you to be able to use EMDR, but there's been more research that's come out that said you don't even have to know what exactly happened to you to benefit from using the EMDR to reprocess experiences and, get into the subconscious and do what you need to do to essentially reprocess that experience. That's what it is you're rewiring the experience. And EMDR stands for eye movement desensitization and reprocessing. And so you're going in, and again, please work with a therapist. Don't try and go at this on your own. When you're doing any type of subconscious work, you have to be very mindful of the fact that you need the guidance of a professional, because we're not supposed to be in there. You're going into the hardware of your computer. You would never go navigate that back end system of your computer and manipulate something that you didn't know how to fix. So you don't want to, you want to make sure to take the same care with your psyche. Okay. Next is clinical hypnotherapy, not to be mistaken with stage hypnotherapy that you see in Vegas with people clucking around like chickens. Okay. But actual clinical hypnotherapy helps to go into the subconscious and reprogram and re-influence certain behaviors. And then lastly is going to be ketamine assisted therapy. Now, this is what my specialty is in. For legal purpose, so for legal and ethical purposes, I don't talk about very specific psychedelic therapy. I only talk about, I primarily talk about ketamine when I'm talking about psychedelic assisted therapy, because all the other types of substances, with very little exception, are still very much illegal. And one of the most important things about participating in any these types of therapy is safety. And it's not just safety of the substance, not just safety of your body, not just safety of your setting and the sitter that's with you. It's also safety in knowing that when you participate in this, that you're not compromising the status of your job and the patch you wear and the badge you wear when you go back to work. Ketamine therapy is a Schedule III substance that is very legal to get with a prescription from a provider. The number of times people whisper to me how do I get that ketamine? You just Google it, look it up. There is a practice somewhere near your nearest major city. Now, I have done ketamine therapy personally. I also studied it in my PhD. This was the focal point of my dissertation. So obviously I have a little bit of a bias towards it, and I very much acknowledge it. At the end of the day, though, it is just a tool. It does not work for everybody, and it does not work without you. Okay, but it does allow you to go into the subconscious, experience, express, revisit certain things, and then you pair it, as with the other 2 things, and then you pair it with an integration session to process that information and those emotions and those feelings and those experiences with a therapist. Okay. Now, if you're interested, and I feel okay to plug this here because it's completely free, but that QR code right there will take you to a 2-hour CE course that I created on ketamine therapy that is 100% free. Okay. And if you're an EMT, paramedic, AEMT, it's also eligible for 2 hours of CAPC accredited CEs. Okay. And then I want to leave you with this quote with talking about and just really reinforcing how much the ketamine is it's the tool, but psychedelics used responsibly and with proper caution would be for psychiatry what the microscope is for biology or the telescope is for astronomy. This is a quote by Stanislav Grof that I think it just encapsulates so well the fact that this is a tool for exploring our psyches. And what an incredible opportunity for us to use in a very safe, medically controlled, and legal way. But that is an option that is available to first responders. Okay, I've got some highlights, and then we're going to shift things over to Q&A, which these are my key takeaways for you, is that it is not selfish to take care of yourself. It is essential. Okay, it's essential to take care of yourself first, and this is going to come in so many different ways that only you can decide. Sleep is 100% your friend. It's going to be your best defense and your best ally against PTSD. Okay, and it's the one thing I think that we're doing the poorest at. You're not your ace. I know we talked a lot about stuff around adverse childhood experiences. And so just a reminder, this wasn't a doom and gloom indicator of what your future is going to look like. It just gives you an idea of some precautions to take and potential risks. Okay, it's not 100% guarantee. Trauma of all types can be healed. So it doesn't matter if there's something that you inherited down the lineage, the family lineage, something you had in childhood, repeated exposures to other people's traumas, maybe some moral injury that you experienced in life. There is a way to go in and do the work with a professional to make it happen. And then I love this quote so much that I want to repeat it, which is that an abnormal response to an abnormal situation is normal behavior. So to have an experience with PTSD following a traumatic call, following a traumatic event is not weakness, it's biology. It's how we're programmed. And even though it happens to one person and not another person, I think more than anything, the awareness around it so we know how to support the people around us is essential. So I appreciate you all being here so we could have this discussion today. Okay, and then before you turn off the recording so that we can do some Q&A. I think I have to turn it off, don't I? I just wanted to put this screen up here so anybody that watches the recording knows how to get a hold of me and be in touch.